Hi everyone, my name is Michelle, and for this video presentation, I will be discussing three topics: trauma-informed approach, treatment of trauma, and recovery-oriented cognitive therapy. Beginning with trauma-informed approach, a great percentage of people presenting with behavioral health problems have been affected by trauma. According to the Substance Abuse and Mental Health Services Administration, trauma is defined as resulting from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. There are three types of trauma. These are natural events such as floods and tornadoes, human-caused accidents such as airplane crashes and trail derailments, human-caused intentional acts such as abuse, neglect, arson, and torture. Traumatic stress increases the risk for behavioral health challenges, including frequency, intensity, and length of experiences. Here are some facts about trauma. In the U.S., 61% of men and 51% of women reported exposure to at least one lifetime traumatic event. In public behavioral health settings, 90% of service recipients have experienced trauma. In the United States, 19% of men and 15% of women reported a lifetime experience of natural disaster. So, how does trauma impact health? Research has found a strong relationship between adverse childhood experiences and difficulties later in life. Compared to those who had experienced none, persons who had experienced 4 or more categories of childhood exposure have increased risk of the following. They had an increased health risk for alcoholism, drug abuse, depression, suicide attempt, smoking, poor self-rated health, and physical inactivity and severe obesity. It was also found that there is an association between adverse childhood experiences and adult cancer. Every person is impacted by trauma differently. Therefore, we need to inquire to assess the effects properly. Safety, sense of control, avoiding re-traumatization, and active participation are all key aspects of the trauma-informed approach. According to SAMHSA, a program, organization, or a system that is trauma-informed will have the following. They will realize the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others involved in the systems, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. A trauma-informed approach can be implemented in any type of healthcare setting or organization, and is distinct from trauma-specific interventions or treatments that are designed specifically to address the consequences of trauma and to facilitate healing. Now, when it comes down to trauma-informed culture, there are 6 principles that must be taken into action. These are safety, trustworthiness and transparency, peer support, empowerment, voice and choice, collaboration and mutuality, and the 6th one is cultural, historical, and gender issues. These principles influence how healthcare practitioners connect with clients receiving services from their agencies. They also guide the way clinicians look at their work and how they implement cultural practices. Apart from these principles, there are also 6 core competencies, which are screening for an assessment of trauma history and trauma-related experiences, such as depression and anxiety, awareness of differences between trauma-informed and trauma-specific services, understanding the bidirectional relationships among substance use and mental disorders for traumatic experiences, engagement in person-centered counseling that focuses on the experiences, goals, and priorities of the individual, competence in delivering trauma-informed and trauma-specific evidence-based interventions that lessen negative feelings associated with trauma and improve quality of life for individuals. And finally, awareness of and commitment to counselor self-care practices that prevent or lessen the impact of secondary traumatization on behavioral health workers. Although all of the above mentioned is important in all clinical work, it is essential to pay special attention to taking care of yourself in trauma-informed settings. As a collaborative process, the trauma-informed approach has implemented the principles, core competencies, and organizational alignment with the domains that go hand in hand. To conclude the portion of trauma-informed approach, we have to make a shift from asking consumers what is wrong with you to what has happened to you. By practicing this, healthcare providers are moving from pathologizing the consumer and blaming the person. Together, the provider and the consumer begin a path of healing as the person gains some control and awareness while participating fully in their own recovery. Now, for the next topic, which is treatment of trauma. Traumatic stress, according to the DSM-5, is exposure to actual or threatened death, serious injury, or sexual violence by either directly experiencing or witnessing in person, learning that the event occurred to a close family member or friend, experience repeated or extreme exposure to adversive detail of the event. It is also important to note that not every difficult, stressful experience is trauma, and that traumatic stress is common. In the USA, the majority, about 90% of adults who have experienced at least one potential traumatic event. Also most common, the sudden death of a loved one, witnessing someone being hurt, and exposure to disaster. And in early life stress, according to the CDC, about 59% of adults have experienced at least one adverse childhood experience. In the aftermath of traumatic stress, some risk factors for lack of recovery have to do with socioeconomic factors, more extensive trauma exposure, social resources, and more severe comorbid symptoms, possibly mediated by genetic, endocrine, and neural differences. Some trauma-related disorders, according to the DSM-5, consist of acute stress disorder and post-traumatic stress disorder. With acute stress disorder, a person will experience at least 9 symptoms. With PTSD, a person will experience at least one intrusive symptom, at least one avoidance symptom, at least 2 negative alterations in cognition and mood, and at least 2 arousal symptoms, including the added self-destructive behavior. Evidence-based psychosocial treatment consists of early intervention, prolonged exposure, cognitive processing therapy, eye movement desensitization, and reprocessing. Additional treatments include cognitive therapy, narrative therapy, brief psychodynamic, among other therapies. Now, to go further into one of the therapies, there is recovery-oriented cognitive therapy. When it comes to the recovery, it is possible for everyone to be able to recover. Some just may take longer than others. However, everyone can play a significant role in an individual's recovery. The theory of recovery-oriented cognitive therapy is supported by diverse research literature in the therapy, and it has been validated in a clinical trial. There are three key factors that people who identify as recovered, that have identified while they're recovered, that are important. These are the ability to engage in productive work, meaningful relationship with others, and being able to manage their own stress experiences. The underlying basic needs of recovery also consist of connection, control, feeling valued, contributing, and feeling safe. All individuals have adaptive mode, which adaptive mode consists of positive emotions and positive beliefs within them, and everyone who works with them can collaborate to promote flourishing. In adaptive mode, it is important for clinicians to meet the individual where they are at. In the stage of connection, there is accessing and energizing the adaptive mode. You can access the adaptive mode through shared interests, doing things together, also asking the individual for advice. Energizing the adaptive mode comes with establishing connection through repeated engagement in meaningful and pleasurable activity. Accessing and energizing the adaptive mode frequently and predictably can help an individual shift to being in an adaptive mode more often. The adaptive mode provides a key to energy, motivation, and the ability to develop and take action towards aspirations. And these aspirations are known as significant and meaningful desires that an individual wants for his/her life. In developing adaptive mode, you need to identify aspirations through the following: using what you know from accessing and energizing to help stimulate ideas, using specific details to help individuals project vision into the future, using interest to acquire about aspirations. Ensuring the individual is in adaptive mode before addressing aspiration, which is the key to success. There are several strategies to elicit aspirations, moving from open-ended to more specific questions. Understanding the meaning of an aspiration increases flexibility and allows a person to live a meaningful life in the current moment. In actualizing adaptive mode, positive action is taken by breaking down aspiration into smaller, achievable steps. Also, by addressing challenges as they impact steps towards aspirations. When challenges arise, they need to be addressed as the individual becomes more active. Positive action extends beyond creating a hopeful vision for the future and emphasizes on collaborative movement toward aspirations. As people make progress toward their aspirations, positive empowering beliefs can be strengthened. Strengthening the adaptive mode can increase opportunity to learn from experiences. It can also draw individuals' attention to positive experiences, and it strengthens adaptive beliefs about self, others, and the future. Common areas of focus include beliefs about energy, connection, capability, control, and strength. Part of strengthening the adaptive mode also includes resiliency beliefs. Building resiliency is building confidence about the ability to handle stressful situations. And this can be done by asking an individual how to solve the difficult situation for someone else, to identify when she or he has had success managing a challenge, to identify minor challenges that have been difficult to overcome and role-play solutions, and to identify more significant challenges and role-play solutions. Some challenges in terms of negative symptoms and challenges with communication consist of negative symptoms, which are what often holds individuals from moving towards the life they want. Activating beliefs about energy, connection, and motivation, which helps with the individual get started. Communication disturbance often occurs when experiencing negative feelings or stress. Their beliefs around disconnection and effectiveness can exacerbate communication challenges. Developing and achieving aspirations mitigates negative symptoms and communication disturbances long term. When it comes to addressing challenges pertaining to trauma, aggression, and self-injury, responses to trauma can be understood using the cognitive model. Beliefs related to disconnection, lack of control, and lack of safety can contribute to both aggressive and self-injurious behaviors. Interventions targeting underlying beliefs can reduce incidents and support movement towards aspirations. Aspirations can provide motivation, purpose, and hope, which can interrupt the cycles of aggression and self-injury. Challenges to progress in terms of delusion and hallucinations. First, we must differentiate the challenges by acknowledging that delusions are beliefs and hallucinations are perceptual experiences. Both are challenges if they get an individual further from things he or she wants in her life or his life. Delusional beliefs are important for understanding the person and their existence. Two common types of delusion are grandiose delusion and paranoid delusion. Hallucinations, which are perceptions without external stimulus, take different forms such as auditory, visual, tactile, olfactory, and gustatory. One of the interventions that is used for hallucinations is refocusing. This intervention helps so that the voices do not interfere as much in the individual's pursuit of aspiration. In conclusion, delusions are protective and have underlying meanings that reflect unmet needs. When these needs are met, delusions are diminished. Hallucinations can be understood in terms of beliefs about them. Interventions that refocus attention away from the voice and onto meaningful, purposeful activity shifts beliefs about control, credibility, and power of the voices. Recovery-oriented cognitive therapy. My final topic. A person's social environment can be a very powerful catalyst for promoting recovery and significant progress. Recovery can be actualized through systemic group programming, clubs, planned interactive activities, and involvement in the broader community. By transforming a person's social environment, the culture of the unit, residence, or agency is transformed. Recovery-oriented cognitive therapy is measurable, and programs can continuously strive for excellence. So in conclusion, trauma-informed approach, treatment of trauma, and recovery-oriented cognitive therapy are three topics that are involved, that are client involved and providers. They encourage patient participation and engage to achieve improved health outcomes. It builds client-clinician relationships to seek interventions that best work for the client. Evidence-based approaches such as recovery-oriented cognitive therapy helps clients shift to adaptive mode, which helps them in process of achieving their aspirations. And that will be all. Thank you for watching.